Whenever I talk to physicians about outcomes that are worse than you'd expect, they're quick to point out that non-compliance, when a patient doesn't follow a course of treatment, is a major problem. Is behavioral economics the answer? That's the topic of this week's Healthcare Triage. Sometimes prescriptions aren't filled. Other times they are, but patients don't take the meds as prescribed. All of this can lead to more than 100,000 deaths a year. A thorough review published in the New England Journal of Medicine about a decade ago estimated that up to 2/3 of medication-related hospital admissions in the United States were because of noncompliance at a cost of about $100 billion a year. These included treatments for HIV, high blood pressure, mental health, and childhood illness, because it can be difficult to get kids to take their medicine too. To address the issue, researchers have been trying various strategies, including those rooted in behavioral economics. So far, there hasn't been much progress. A systematic review published 5 years ago in Annals of Internal Medicine looked at all kinds of trials that tried to improve patient compliance. It found some limited successes in improving patient compliance in different disorders, but most of the trials were small and not easily generalized outside of the research setting. A more recent Cochrane review concluded, and I'm quoting, "The current methods of improving medication adherence for chronic health problems are mostly complex and not very effective." At first glance, behavioral economics, the basis of Richard Thaler's recent Nobel Prize in economics, seems like a rich field of potential solutions. People tend to do things like donate organs when it's the default option as opposed to something they need to request. They tend to be less likely to miss appointments if you tell them how many other patients show up for theirs. They tend to be more likely to engage in preventive behaviors like using sunscreen if you focus on the benefits, not the harms. Many are turning to ideas like these to improve medication adherence. But those excited about the potential of behavioral economics should turn to the research. A recent study pulled out all the stops in trying to get patients who had a heart attack to be more compliant in taking their medication. Patients' adherence at such a time is surprisingly low, even though it makes a big difference in outcomes, so this is a major problem. Researchers randomly assigned more than 1,500 people to one of two groups. All of them had recent heart attacks. One group received the usual care. The other received special electronic pill bottles that monitored their use of medication. Those patients who took their drugs were entered into a lottery in which they had a 20% chance to receive $5 and a 1% chance to win $50 every day for a year. That's not all. The lottery group members could also sign up to have a friend or family member automatically be notified if they didn't take their pills so that they could receive social support. They were given special access to social work resources. There was even a staff engagement advisor whose specific duty was providing close monitoring and feedback and who would remind patients about the importance of adherence. This was a kitchen sink approach. It involved direct financial incentives, social support nudges, healthcare system resources, and significant clinical management. It also failed. The time to first hospitalization for a cardiovascular problem or death was the same between the two groups. The time to any hospitalization and the total number of hospitalizations were also the same. So were the medical costs. Even medication adherence, the process measured that might influence these outcomes, was no different between the two groups. The researchers in this trial deserve praise for their frank assessment of their results, as well as for trying to brainstorm ways in which they might achieve success in the future. Getting patients to change their behavior is very hard. In the past, we've tried making drugs free to patients to get them to adhere to their medications and improve outcomes. That failed. We've tried lotteries, like in the study I just mentioned, to nudge people to achieve better compliance. That failed. Maybe financial incentives and behavioral economics in general work better in public health than in more direct healthcare. There have been some successes, after all, with respect to weight loss, although those seem to disappear over time. We've also seen promise with respect to smoking cessation, which we've covered in a previous episode, although those come with caveats as well. Experts caution that the interventions that achieve success are often very intensive. They demand a great deal of attention and can be quite expensive. Moreover, they're very focused, usually on a single issue or condition. The problem is that healthcare has so many moving parts. The healthcare system has even more. Trying to improve any one aspect can make others worse. Behavioral economics may offer us some fascinating theories to test in controlled trials, but we have a long way to go before we can assume it's a cure for what ails Americans. We like to make videos about topics that sometimes YouTube doesn't like to sell to advertisers, and we're fine with that because we're gonna do what we think is important. But it helps to get support from viewers like you through things like Patreon.com. Patreon is a subscription service that allows you, the viewers, to support the show and the content we create in ways that don't have to go through all the rigmarole with ad fees and all that stuff. You can go to patreon.com/healthcaretriage if you'd like to support the show. We'd especially like to thank our Surgeon Admiral Sam and our research associates Joe Sevitz, Joshua Crow, and Carlos Gallegos. And if I'm pronouncing that wrong, Carlos, you let us know. While we've got you, we'd appreciate if you'd subscribe to Healthcare Triage, like the video, and I also have a new book out. The Bad Food Bible makes a great holiday gift.